Good afternoon, and thank you for joining the RLS Foundation's webinar titled RLS and Drug Holidays. My name is Carla Diezenkowski, and I'm the Executive Director of the RLS Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Early will answer as many questions as time allows with his presentation. After the webinar, you will
muted
email with a link to the webinar recording. The webinar recording will also be made available in the members-only section of our website. If you're not a Foundation member and you would like to view this and other recorded webinars, we invite you to become a member today by going to www.rls.org. Our speaker today is Dr. Christopher Early. Dr. Early received his medical degree as well as his PhD in pharmacology from the University College in Galway, Ireland. He completed his residency in internal medicine at Baylor Medical College and then went to the University of Virginia in Charlottesville to complete his residency in neurology. Dr. Early spent a year at the National Institute of Health as a fellow in neurobiology unit before joining the faculty at Johns Hopkins in 1991. Dr. Early's research and clinical interests are devoted to sleep medicine with a special interest in restless leg syndrome. His current research is focused on understanding the pathophysiology of restless leg syndrome and further revealing the value of various treatments in this syndrome. Dr. Early is a certified provider at the Johns Hopkins Center for Restless Leg Syndrome Quality Care Center in Baltimore, Maryland, and is a member of the RLS Foundation's Scientific and Medical Advisory Boards. Dr. Early, we thank you for sharing your time and your expertise with us today. I now invite Dr. Early to begin his presentation.
Thank you, Carla. I've been asked to talk on the topic of what's called a drug holiday, essentially getting off of medications, and I'd like to provide you with some basic rationale and some case studies of individuals that have gone that pathway to sort of give it a sense of reality about how people do it and why people do it. When we talk about drug holiday, the usual reasons that people do this is to either discover or reevaluate the need for medications. So essentially patients find the medication is working well, but the question is, do I still need to be on this medication? The other is, the medication is working well, but the patient asks, do I really want to be on this medication? And then the final one is, you're having problems with the medication, the current medications, and I need to come off of them. So those are the usual sort of thoughts that go through people's minds when they decide or make some decisions about whether to come off the medication or not. So to see if the medication is still necessary, there are some basis for considering that. One of the relevant outcomes of our family history study, during which time Requip and Mirapex actually had not been formally approved by the FDA, so the majority of patients with restless leg syndrome actually had not been treated. In fact, 80% of the patients identified in that family history study were not on medications. What that study showed is that often patients' natural history varies over time. There were patients whose symptoms started in their 20s and disappeared sometime in their 40s and 50s. There were patients whose symptoms started for 10 years and disappeared after a year or two and came back. They were mild in one part, severe in the other. So there is a natural variance over time in symptom severity and presentation. The other issue is there are potential triggers or aggravants that may be reduced or eliminated after you've been treated. For example, patient has restless leg symptoms, also has an iron deficiency, they go on some medications, it's some time later that they finally get treated for the iron deficiency. Do they still need to be on medications? Patient has sleep-related problems that go beyond the restless legs. For example, sleep apnea. They get treated for the restless legs, they get treated for the sleep apnea. Have I treated the sleep apnea adequately? If the answer is yes, is my RLS going to be better? Do I need to be on the medications? That's a good question. Pain conditions, particularly back and knee problems, can aggravate the restless leg symptoms. And therefore, if you had some trigger like knee pain, RLS symptoms get treated. At some point in time, you get a knee replacement. You no longer have pain. Is your RLS of the same intensity? Do I need this much medication? Do I need any medication at all? Again, same thing, on an antidepressant. This is a common variable. Patients have RLS symptoms, they have an antidepressant, they get treated for the RLS symptoms, and at some point in time they come off the antidepressant. What's the state of the RLS symptoms? It's hard to say because sometimes the medications that they are on are causing the symptoms, and therefore they don't know what the true biology of the symptoms are so long as they remain on that medication. Again, pregnancy is a good example of when symptoms come and go relatively rapidly. You may have symptoms, women may have symptoms during pregnancy, which may take several weeks or months to resolve after the delivery. But if you have symptoms a week or two later after the pregnancy, you may decide to go on medications. Once you go on medications, at some point in time, that medication may drive the symptoms, even though the underlying biology has corrected itself. So this is a 82-year-old woman who I'd seen. She had had restless legs for 22 years. She was on gabapentin and doing very well. No symptoms were needed. She was great. Okay, so on treatment, she had no symptoms. Her current dose was 1,800 milligrams at bedtime. Her ferritin was 117, so reasonably normal. By happen chance, her prescription, she ran out of prescription. It was a holiday, so she couldn't get her medication. So she went on a forced drug holiday. And so she was 6 days without medications. By the time she got around to calling the doctor, which was me, she then only had occasional, minimal symptoms and decided not to go back on the hydrocodone. And we put her on just a small dose of hydrocodone, which she would take when she needed it. In this case, maybe once or twice a month. This is a 70-year-old gentleman with a history of restless legs for 12 years. He was on Requip and then converted over to Mirapex at a dose of 0.75 milligrams. The RLS was throughout the day. He had significant daytime sleepiness, all consistent with augmentation. He had a ferritin of 154, so well within the normal range. He was on venlafaxine, or Effexor. It's an antidepressant. He had been on 150 milligrams for 12 years, which is about the same time he actually had his RLS symptoms, worth noting. Took him off of the Mirapex, went through an 11-day withdrawal period as per my routine. He still had nightly symptoms, though the symptoms were improved off of the Mirapex. I then took him off the venlafaxine for 5 days. As soon as I got him off the venlafaxine, he no longer had any restless leg symptoms. This is a 64-year-old man, restless legs for about 6 years. He donated blood to the Red Cross about 3 or 4 times per year, was also on a lot of non-steroidals. I think it was naproxen or something like that for some arthritis. He was on Pramipexole for about 6 years at a reasonable dose. His ferritin was 35, which is low. In fact, for a man, it's exceedingly low. I gave him an iron infusion. I waited 6 weeks after the infusion, which is the maximum time for the iron to have its effect, and then I tapered him off of the Pramipexole. He went on the 11-day drug-free period and no longer had symptoms. In fact, I have followed him for the last 11 years, and he remains relatively asymptomatic as soon as symptoms come back in him. We check his iron level, and lo and behold, it's usually down. I give him another infusion, and it goes back for another 2 years of no symptoms. So the question is, do I really want to be on a drug? Which is some of the patients ask that. So this is not about whether you need the drug. The question is, do I want to be on this drug every day for the rest of my life? And it's not an unreasonable question. Obviously, I think many RLS patients face that question. It's a balance between what your RLS symptoms would be without the medication versus what they are with the medication. So this is a 75-year-old gentleman. He had restless legs for 55 years. For most of those years before I saw him, for actually about 40 years, he had a bicycle, exercise bicycle, beside his bed. He would exercise for 20 minutes. The RLS would go away. He'd sleep for 3 hours and wake up with the RLS and cycle for another 20 minutes and go back to sleep for another 3 hours. He was enticed by advertisements on TV about the Mirapex, and so we started on the Mirapex and got up to a reasonable dose of 0.5 for about 8 years. The medication was working fine. He never thought his sleep was all that great, but the RLS was gone, and relatively speaking, he should have been satisfied, but he wasn't. He decided he just didn't want to be on medications, so I tapered him off. He went through a 14-day drug-free period, and his baseline symptoms, he was back to what he was before, nightly symptoms, somewhat milder than what they were when they broke through with the Mirapex, but still there every night, and he returned to his bicycle, and he was happy just to cycle before he went to bed and cycled middle of the night because he felt he was happier just being off of drugs. So the other issue that people have, a reason that people need to get off medication, is because you're having problems with the medication. So you're on the medication for an extended period of time, and now there's some problems that pop up. Usual problems are there's side effects from the medications after chronic use. There's tolerance to medication, so the amount that was working before isn't holding you, and that's usually will occur with the opiates or the alpha-2 delta agents. And of course, augmentation with chronic use, and that occurs with the dopamine agents. Then occasionally in this day and age, particularly since January of this year with all the changes in insurance, I'm finding a lot of patients that their insurance companies are no longer paying for the medication. So there are financial issues, and we have to get them off. So this is a 61-year-old woman who I'd seen with 15 years of restless legs. She'd been on methadone 10 milligrams for about 5 years. She was complaining of daytime sleepiness, which is not an uncommon side effect with the methadone in a small number of people. Ferritin was 110. So I tapered her off the medication. I put her through a 10-day drug-free period, gave her a drug holiday. The symptoms of RLS were still there in the evening, so we returned to the methadone, but it was at a lower dose of 7.5, and she no longer had the daytime sleepiness. So from her point of view, coming off the medication was a valid effort because now she was back on medications, symptoms were treated, and she didn't have the side effects. So this is a 47-year-old gentleman, 30 years of symptoms, essentially since his teens. He was on dopamine agonist for 15 years. Probably had what was augmentation per history. He was converted by his doctor from the dopamine agonist directly over to oxycodone extended release. There was no holiday in between. When I saw him, he was on 40 milligrams of oxycodone, or OxyContin, 3 times a day, so 120 milligrams of total oxycodone. His ferritin was well up in the normal range. Period. So I spent some time with him and took a month or so to actually get him off of the oxycodone. I had him on an 18-day drug-free period. He still had nightly symptoms. They were much improved, however, relative to what they were during the withdrawal process and obviously during the period of time that he was on the oxycodone. They were primarily sort of mid-evening to bedtime. So I restarted him back on the oxycodone, this time at just 10 milligrams and 20 milligrams, which you can see is substantially reduced from what it was before. The benefits of that reduction was the significant side effects he was having from the higher doses of oxycodone before. So he was quite happy. So 62-year-old woman, 37 years of restless legs, re-equipped for 12 years. She was augmented. Current dose was 4 milligrams. Ferritin was 113, so within a reasonable normal range. I tapered her off. Her 11-day drug-free period. At this point in time, she was having essentially mild bedtime symptoms compared to essentially symptoms that were occurring in the earlier part of the afternoon. They were, however, only occurring maybe 4 to 7 nights per week. and she'd get up, do some exercises for 10 minutes, and was able to go to sleep and sleep solidly for about 5 to 6 good hours. And she decided she did not need to go back to medications, that she could handle her symptoms the way they were. So I would like to sort of talk about the number one reason why people come off medications or have problems with medication, and that's essentially the issue of augmentation. There are consequences to having a dopamine agent on chronically. Basically, you have the receptors. These chemicals bind to specific receptors in the brain and create a dopamine-like signal. When you use these drugs chronically, you desensitize and affect these receptors, so they get in an unnatural form. You have various shifts in the types of receptors, the concentrations of the receptors, and the distribution. All this in a way leading to an abnormal balance and subsequent apparent worsening of your restless leg symptoms, which we call augmentation. These receptors interact with other parts of your brain, other systems, and those interactions are also become abnormal. And in the end result of all this excess of dopamine in the brain is that it tends to feed back to your natural dopamine system and turn it off. So I'd like to give you sort of a basic illustration or conceptualization of the dopamine activity in your brain and how this augmentation might be perceived from a biological point of view. If we look at this curve as if it represents your natural dopamine activity in your brain, what we understand is your natural dopamine levels somewhere around 4 or 5 o'clock in the morning start to go up and reach a peak in the early parts of the morning, then slowly come down as the day goes on. And as you approach the evening, your natural dopamine levels reach their lowest point and then head back up. So it oscillates in a circadian manner. In restless leg syndrome, we believe that that oscillation drifts downwards. You still have a peak level, but it's lower, and you have a nadir, but it's lower. And we believe it drops below a critical threshold, so that the amount of dopamine that you need and the actual amount that you're making is low. So now you get symptoms starting in the evening, disappearing in the early mornings. So you have your first onset of symptoms that are just at night or at bedtime. If I give you a dopamine drug, whether it's levodopa, Requip, Mirapex, or Nupro, I am telling the brain, here's all this extra dopamine. And the brain, being the smart organ that it is, says, heck, why do I need to make it much? And so your brain starts turning back its own production. So your own natural levels of dopamine go lower. You still have the peak, the protective period, but now the level drops down sooner. So your symptoms start coming on earlier, and the levels go lower. So now your drug isn't working as well. And when symptoms break through, the difference is huge, and your symptoms are even more intense. So this is what we believe is the basis of augmentation. Why initially the drug seems to work, but as time goes on, the drug is actually making the symptoms worse because you're reducing your natural dopamine levels. Obviously, since by adding the drugs, I was able to reduce it. If I slowly pull those drugs back, I can hopefully, and I do believe, bring those dopamine levels back to at least what they were before, and sometimes in cases back to something that's closer to normal. So augmentation is a result of the chronic use of dopamine drugs, which results in a decrease in your brain's natural levels of dopamine or dopamine activity, and an increase in dependency on the drug. So how do I restore my natural levels of dopamine back to their levels? By reducing the dopamine drug, I create an inadequate amount of dopamine in your brain. So your brain's dependent upon the reequilibrium of Mirapex. If I reduce that, then the brain sees less dopamine. Therefore, your brain will begin to produce its own dopamine. However, there's going to be a lag time from the time you drop the dose to the time your brain makes more. Reducing the dopamine drug, reducing the requip, reducing the Mirapex, as I said, will reduce the amount of available dopamine in your brain, and that will also lead to an increase in your restless leg symptoms. Decreasing the dopamine equals increasing your symptoms. You can't have one without the other. Eventually, you'll have a natural production or increase in production of your own natural levels, which will lead to increasing improvements in your RLS symptoms. But it all takes time from the point of coming off the medication till finally you're able at some point in the drug-free period or drug holiday to see some improvements in your symptoms. So there are various approaches to getting people off the dopamine agonist, and I've tried just about every possible combination. And my approach at this point in time is to take people off the dopamine agonist without considering alternative coverages. Now, there are some people, experts, RLS experts, who do consider coverage. They'll use methadone or opiates, other opiates, to cover the difference. But there are I have concerns about what is the end result of all that. But if we consider a drug holiday from a dopamine agonist, we start with a taper. That is, we got to take you from your current high dose and move you down to eventually getting you off. Many patients who are augmented are at very high doses. Going completely cold turkey is crazy. It is going to be the worst experience that you ever had. So you should incrementally reduce the dopamine agent. These are a suggestion only, a suggestion. If you're on Pramipaxil, then you should reduce your dose by about 0.25. If it's Requip, reduce by 0.5. If it's a retigotine patch, reduce it by 1 milligram. How fast do you reduce it? Again, here's my recommendations. Each reduction should be no quicker than 3 days, but could be as long as 5 or 6 days. Some people want it fast and furious. Some people want it slow and obscene. It's how you want to take it. That's essentially it. Because as you drop down on these doses, your restless legs will definitely act up, and you will lose sleep. But the real and most difficult part of the drug withdrawal and getting into that drug-free period or drug holiday is the drug-free period. So we're talking about once you've tapered down, when you start with that first night with no medications. So for day 1 and 2, the RLS will be horrendous. There is no other words for it. And you will get absolutely no sleep. Absolutely. Guaranteed. 0 sleep. For day 3 and 4, off of the medications, the RLS will still be severe. However, you will get maybe 1 hour on day 3. You'll crash the early parts of the morning, maybe get 1 hour on day 4, maybe a half hour, maybe sometime earlier in the morning, 9 or 10, you might get an hour or something like that. But essentially, for the first 4 days, you'll be lucky to get 1 or 2 hours of sleep. Because of the chronic sleep loss for the preceding 48 hours, the excess amount of sleepiness on day 3 or 4 will be significant. So you shouldn't be driving or doing anything that involves attention and concentration, depression, anxiety, and a real almost need addiction to go back on the drug will be very, very strong. Day 5 through day 7 is a improvement both in the intensity of the symptoms, distribution. If the symptoms have to be in your upper extremities as well, they start coming down to just your legs. If the symptoms are morning, afternoon, and evening, they start going back to something that's afternoon or just evening. So there's a beginning, a rolling back of the symptoms, both in duration and intensity. Sleep is up to, at best, 2, maybe 3 hours, occasionally 4 hours of sleep. It says day 10 to 14, but actually it should be, it should be day 8, 9, and 10. There is further improvements both in duration, intensity, and the amount of sleep. At a minimum, you'll be up to about 3 or 4 hours of sleep. At the max, you'll be up to 5 or 6 hours of sleep. It will be fragmented. It's not going to be consolidated sleep. The symptoms are likely to abate back to something that was not dissimilar to what you had before you started on that dopamine agent. And so if your symptoms were at bedtime, it's likely to go back to bedtime symptoms. If it was evening, it'll go back to evening symptoms. There is a small number of patients, approximately 15 to 20% of patients, who will report that their symptoms have remitted, that on day 10, 11, 12, after the drug withdrawal period, that they no longer have symptoms. So when is the drug holiday over? What to do next? I'm often asked after my 10-day drug-free holiday, will the symptoms continue to improve? I have chosen the 10-day period as an arbitrary endpoint that I believe is not too far away. It's within the grasp of the patient. When you're there on the second and third and fourth night of no sleep, the idea that Dr. Early said it's only day 10, so I only have to wait another 5 days or another 6 days, is a lot easier to believe in than if I told you you had to go out not 10 days but 2 weeks. I used to do 2-week withdrawal symptoms, but my failure rate was about 30%, so I moved it back to 10 days. Patients who don't return to medications offer me an opportunity to see what happens, and many of those patients will continue to have improvements in symptoms. And I've had patients who continue to have improvements out 3 and 6 months after the withdrawal period. So 10 days, 11 days, 12 days is not the necessary end of the withdrawal period. There is still potential room for improvements in some patients. Living drug-free with RLS is a personal decision. Just because you have restless legs doesn't mean you need to be on a drug. As all RLS sufferers know, it's about the intensity of the sensation. It's not that it's there every night. If it was relatively mild, you could do a couple stretches, you'd probably be fine with it. It's your decision about what you can or can't live with that should drive your decisions about to treat or not treat. Once you've been augmented, you will always be augmented. I don't care if you wait 10 years, you go back on that re-equipping Mirapex and you'll be back augmented within a few months. The other you may return to prior drugs if not dopamine agents. In some of the examples I gave you, I showed you where the patient went back to methadone, went back to oxycodone, and I've had cases where patients developed some tolerance, got them off the drugs, drug-free period, put them back on the gabapentin. So you may decide to return to the medications. Again, if you do, start low and slowly work up, because you may not need as much as you had before. And obviously, always try an alternative. So if you're on a dopamine agonist, you get off that, you want to go back to treatment, there's the other categories, which are obviously the alpha-2 delta agents and the opiates. I would remind you that there is a pamphlet brochure information that talks about the drug holiday and Russell Lake through the Russell Lake Foundation. So I'd like to conclude this discussion with a sort of question. So when someone says holiday, as in drug holiday, what do you think of? Obviously, when we talk about holidays, we think about, warm Caribbean beaches, blue skies. When you talk about a drug holiday in relation to Restless Leg syndrome, you have to understand this is the true reality of what a drug holiday is. There is absolutely no way that anyone can get off the medications, particularly the dopamine medications, without going into a very deep, dark place for a short while. And so if you have any ideas about a drug holiday, you need to plan for this. You need to be sure this is what you want to do. You need to know what potential endpoints. When I'm finished X number of days, what am I going to do? So you want to make sure this is well planned. You don't want to get into this for 3 or 4 days and then have to bail out. That experience will burn deep into you for the rest of life, and you'll probably never ever do another drug holiday. Thank you. End of the show.
Thank you, Dr. Early. That was a great. Not yet. We've got Q&A for you, and I think everyone we've got. End of the presentation, but we have a lot of questions that were submitted, and they're great questions. I want to thank everyone who took the time to submit that question with their registration. So I'll go ahead and start with the first question. Please discuss withdrawal symptoms and the possible duration associated with a drug holiday.
Well, the withdrawal symptoms are all essentially the same in terms of medications, whether it's opiates, whether it's gabapentin, or whether it's the dopamine agonist. Your restless legs will act up. That's the base of all reactions. The degree to which you lose sleep will define the other complex problems associated with the drug holiday. With all of the dopamine agonists, when you get off of them and when you've been augmented, you have significant sleep loss, as I mentioned. 4 days with no more than an hour or two of sleep. Depression, anxiety, decreased interest, decreased drive, obviously lethargy. Those are the big ones. There are, in individuals, other small idiosyncratic reactions that people have when they lose that type of sleep. They may become extremely irritable, personality changes, hard to live with, all those other things. And so outside of those particulars, there may be smaller things. Opiates, people talk about opiate withdrawal and cite various things they found on Google searches. Opiate withdrawal in restless leg syndrome is not the same as opiate withdrawal in people with chronic pain. They are different diseases. Chronic pain is a disease. It may be a particular disease that got you there, but chronic pain really is altered biology and thus disease. And how the opiate system interacts within a pain pathology is not the same thing in restless legs. For most people, restless legs has nothing to do with pain. I have had little in the way of problems of people coming off of opiates if, and I point out if, that opiate was started at their untreated baseline. If you were on a Requip or Mirapex and then were put on an opiate like methadone, all you did is take the augmented state under the Requip and move it to the augmented state under the opiate. And when you withdraw from the opiate, you will have the same horrendous withdrawal symptoms that you had with the Requip. And that is my reservation about some people deciding to do the drug withdrawal by converting from one drug to the another. I don't think you're able to do it. All you're doing is, as they say, moving the chairs around on the deck of the Titanic. Nothing more. Next question.
Does drug holiday mean no drugs to help me get through the jerking, or any sleep aids, or just no Requip?
I don't have patients on anything. Again, some of the other oral specialists will use opiates as a way to attenuate or blunt. You can blunt the withdrawal, but then the withdrawal gets protracted out to 12, 13, 14, 15 days. And the question for me is always, trying to ascertain how long can this patient suffer for. First, they have to go through a withdrawal period, the tapering period itself. So you're 2 weeks, 3 weeks, 4 weeks of just getting down on the drug before you have to hit the 10-day withdrawal period. And I think the more you ask the patient to do to extend their life out to that, the harder it is for anybody. And I used to use the opiates as a way of attenuating the symptoms, but in the end I found that I was going out 14, 15 days, and I don't think I was gaining much out of that. If there are patients who stop, get to day 3 and 4, can't do it, go back on the medication though at a lower dose, I will work with them to see if I can find some other way to eventually get them off that. From the point of view of sedative hypnotics, you should never ever use anything that sedates you. No Klonopin, no antihistamines, none of that. Okay. Since what is happening with the withdrawal symptoms is that you're trying to get up and walk. If you use a sedative medication, it will only partially sedate you, and therefore you'll be up walking like a zombie, fall, and break a hip. Next.
Okay. Does RLS ever go into remission?
Yes.
That was simple. Given the problems with dopamine agonists, why are these drugs even prescribed for RLS?
Good question. Because marketing was faster and better. What can I say? The truth is, no one, your average physician, 99% of your average physicians knew nothing about RLS. And approximately 11 years ago, Requip got FDA approval and splashed advertisements all over the TV. Two things happened. The average patient who had RLS suddenly felt that there was a wonder drug out there, so they rushed to their doctor's office, whether they thought they needed it or not. And two, the drug rep said, if an RLS patient rushes into this door, hand them this. And that's exactly what happened. There was no education, no nothing. So you walked in the door and you said, "Doctor, I have restless legs." And he said, "Here, take that." And that's how it all began, and that's how it all still persists. Lack of education, lack of knowledge about the value and limitations of the dopamine drugs. Next question.
Okay. Has medical cannabis been proven useful for RLS? If so, would it be worth trying for severe RLS before starting stronger opioids?
No, it has not been proven. There is no scientific data. So I don't know what to say. It just is. There are people, some of my patients who said they use it. Second is that I think people are deceiving themselves in believing somehow that an opiate is an evil thing and cannabis isn't. I think that's a horrible misconception.
Okay. How do I stand the symptoms while on a drug holiday if I'm not taking any meds? Can you offer any coping strategies?
Sorry, repeat that again.
How can I stand the symptoms while on a drug holiday if I'm not taking any meds? Any coping strategies you can recommend?
Okay, so the standard, well, what my patients tell me, and I pass it on to my next patient as I detox them off the medication, is during the first 4 days of that drug-free period, it is essential that you learn how to you do something to occupy yourself. Obviously, getting up and walking around will take care of the symptoms, but 11 o'clock at night comes for the first night, and the second night, the third night, and the fourth night, and you just cannot sleep. You have to keep walking. Some of my patients have done things like paint the whole house. One of my patients brought in a dumpster and cleaned out her whole attic. One of my patients was a composer, and actually, even though in the process of composing, he actually could sit down. Another was that he built model boats, and that's what he did. So my recommendation is prepare yourself for this. It's, as I said, you've got to prepare yourself. Think about what you're going to do to occupy your time during that, particularly during that 4-day period, particularly at night from 10 o'clock at night to 8 or 9 o'clock the next morning. That's the important part. Everyone's going to be asleep, and you're going to be up. You don't want to be there pacing, counting each minute. That's my advice. Next.
Okay. How long does one remain off the drugs when on a drug vacation? Then do you try them again?
Well, as per my presentation, I use a 10-day drug-free period. As I said, it's an arbitrary endpoint because it is, I have to do something that's viable for the patient. So most patients can succeed. I will have people who will stay off 14 days or 3 weeks by their own volition. They want to see if it will get better. And I will return people to medications if it is a alpha-2 delta agent or an opiate, not if it is a dopamine agent.
Okay. How long does the drug holiday have to last?
Well, I think at a minimum it needs to last 10 to 12 days. At a minimum. I think people are coming back to close to a baseline at about 10 days. I think a drug holiday at day 7, 8 is still too early. I think 10 days is your minimum. And even then, I am always concerned that had I let that patient go out 14 days, because at 10 days you may decide I want to go on medication, right? If I put you on medication, I am going to be treating you treating those symptoms, and I'll be going up on a drug to a level to treat those symptoms. But what happens if those symptoms were going to improve in a couple of weeks? Then I'm obviously using more drug than I need if I need the drug at all. So that's my reservation as to trying to discover what is the true point at which the biology has reversed itself. And 10 days is the absolute minimum, but you could go longer. Okay.
Okay. I've augmented on Mirapex and went through a horrible detox. If I went back on Mirapex, would augmentation happen sooner the second time around? Knowing how difficult the detox was, I don't think I could survive going through it again.
As I said, yes, you will detox. In the same way that we get permanently addicted to things. You may have smoked for years, given up for 10 years. If you go back to that cigarette, you will be addicted again. These drugs are dope. They stimulate the dopamine system. The dopamine system is intimately involved in addiction and dependency and reward and satisfaction. Your brain has learned a chemical set, like it's been imprinted in there. You go back and stimulate it with a little Requip, Mirapex, or any dopamine agent, and you'll be back to where you were within literally weeks to months. Next.
Okay. I've been taking 5 milligrams of methadone for 1 year. I'm doing quite well. Why take a drug holiday?
Well, as I said, the reasons people take drug holidays is, one, you're having a problem with the medication. 2, that you wish to know if you really need it. And 3, you decide that you just don't want to be on medications. I unfortunately have people who have been on methadone doing great, who are socially stigmatized by being methadone. They don't want to be on it. It's unfortunate, but it's real. People have their beliefs, and they're affected socially by certain implications. And so essentially, if there were reversible factors, as I mentioned before, iron deficiency, sleep apnea, those factors, if they were involved or present during the period of time that you had your symptoms and were treated, and those factors were reversed, that would be a reason to consider whether or not, 1, do you need the methadone, and 2, can you get away with less? Can you get away with 2.5? That's the real reason why.
Okay. I've been on Mirapex for 18 years. Can I stop it and just take alpha lipolic acid instead?
I don't know what the dose is, but I have no doubts that individual is physically, if not emotionally, dependent on that drug. If you go cold turkey, you go through withdrawal symptoms probably significantly greater than the usual 10-day withdrawal period that I experience, because I taper people down. If they want to get off the medication, then they need to taper down. And obviously the tapering period depends upon how much they're on. If you're on 28 milligrams of Requip, it's going to take you 6 months. If you're on 3 milligrams of Requip, it's going to take you, a couple weeks. So that's a personal decision whether to come off and that decision is obviously is complex based upon information obviously that I don't have available to tell.
Okay. I've heard that RLS symptoms decrease with age. I'm 80 years old, and if anything, they are getting worse. What is your experience?
The data about decreasing with age is based upon the risk study where they looked at the prevalence of RLS symptoms in the population, and the prevalence increases with age, and in the group that was 80 years or older, the prevalence dropped. That's a different statement than saying an individual's RLS is going to improve. I've never found that age per se is necessarily predictive of things getting better. They are predictive of getting worse. You know, your symptoms start at a certain age. The probability is that they will get worse with time. How much, whatever, it's a variable. There is definitely some people whose symptoms wax and wane. They can have it for 10 years, and out of the blue, they seem to stop. I'm not sure that's related to being 40 years of age or 80 years of age. I never thought it's a time question and an individual question rather than an age-related question. So I'm not surprised that their symptoms are still there. If they are worse, then you have to think about what else is intervening. Are there iron deficiency issues? Are there sleep-related issues? Are there neuropathies happening? Are there other medications going on board that might be aggravating it?
Mm-hmm. Okay. If you can make it through the withdrawal period, why would you want to go back on any medication?
Good question.
Yeah.
So, you know, going back on medication is a personal decision. That's all I can say. I don't know what to say. You know, it's a very, very personal. It's not something that your family should tell you. It's not something that your spouse should something. It's something that you have to decide about, both to take the holiday and make decisions about at the end of that holiday what you want to do and what you can live with.
Okay. Should one go off their medication if they're not having any signs of augmentation?
You know, as I said in the beginning, the issue of a drug holiday is a personal decision. If you're not having problems with the medications, if you're happy with what you are, if you think you're getting you know, enough out of it, that's fine. You know, one of the examples I gave you was the woman who was on the gabapentin and everything was hunky-dory. She would have stayed on that, and I'm not going to push anyone to come off of it. You have to make the personal decision. But she, by happen chance, her prescription ran out, and she went off, and she happened to find that she was better. So things like that happen. But unless things like those things happen, you're not going to know. So the decision to take a drug holiday falls on. Decision is, do I really need this drug? You ask that question, you make the decision. Do I want to be on this drug? And am I having a problem with the drug? If you're happy with the drug, you don't think you need to be on it, and you're not having problems, then heck, why take a holiday? A holiday, I'm telling you, a holiday this is not a Caribbean holiday here. So.
Okay. Can you explain the difference between gabapentin and gabapentin enacarbil, and why are these medications beneficial to RLS patients?
Gabapentin enacarbil has a little chemical tail put on to the gabapentin. So you have your basic gabapentin molecule, and they put a equivalent of a little extra structure attached to the primary gabapentin. This produces a much more absorbable drug, what we call linear. That is, the amount I give to 10 people, the same amount is going to end up in their bloodstream. What happens is the gabapentin enacarbil crosses over into the liver, and the liver enzymes cleave that little tail off, and what actually gets into your blood is gabapentin. So the regular gabapentin and the gabapentin enacarbil, the result is your blood has gabapentin, and it goes to your brain the same manner, same form. It's only a question of absorption and what's called pharmacokinetics. That is your ability to absorb it. The problem with regular gabapentin is it's highly variable. One person could absorb 10%, another could absorb 80%. When an individual is working, sometimes they could be, one day they could be absorbing 10%, next day they could be absorbing 15%, some days 5%. So the problem with regular gabapentin is that it's relatively variable absorption between patients and within patients. And that was the whole basis of developing the gabapentin anticarbal. Once the gabapentin is in the bloodstream, there's no indications it works better or worse than the gabapentin anticarbal. So they're both acting on the brain the same. One is, cheap. The other is very expensive.
Mm-hmm.
As far as its action on the brain, it is functioning to modify the flow of calcium into nerve cells. Nerve cells are electrically charged. That charge is because of ions like calcium being more on one side of the membrane than the other side. In conditions like restless legs or with any sensory condition, the flux or flow of calcium from the outside to the inside can sensitize the sensory receptors or sensory part of the brain, making them more likely to have pain, discomfort, or restless-leg symptoms. And essentially by giving gabapentin or pregabalin, you modify those calcium receptors so the flow doesn't get overly excessive. It doesn't block it, it just keeps it from getting overly excessive. We believe that that calcium change is relevant to the release of glutamate, and thus that glutamate relevant to the changes that we see in the dopamine system. And that's probably the sort of crude understanding that we have of the biology and relationship between gabapentin, calcium channels, and glutamate and dopamine.
Mm-hmm. Is transcranial stimulation a viable treatment?
Not at this time, no.
Okay. Why is RLS considered a circadian disorder?
If you take a patient and put them in what's called a constant routine, that is, you put them and lie him in bed for 36 hours. Basically, every hour he can do the same level of routine. He can sit, he can read, he can eat a little bit. So his routines are exactly the same every hour, but each hour is different, 8 o'clock, 9 o'clock. So time is the only thing that's changing is time. Otherwise, routines are constant. If you measure your restless leg symptoms, even though the patient is at rest over a 36-hour period, the restless leg symptoms are relatively mild, existent, maybe even not existent at all at 6 o'clock, 7 o'clock, 8 o'clock in the morning. As the day goes on, the symptoms become more likely and much more intense. And so even though restless legs is brought on by rest or inactivity, the threshold at which that resting is likely to induce is driven by underlying circadian mechanisms. And circadian mechanisms are essentially the complex systems that are involved in causing our bodies to change over the 24-hour period. The morning person, the afternoon person, and the evening person are all different because our biology is changing. We're much more active. We have a greater metabolism, and all those things change as we cycle through the day. And that's sort of the circadian rhythm issue. And that circadian rhythm biology, which drives metabolism, activity, interest, also drives the threshold for you to develop restless leg symptoms at rest.
Okay. How do you know if a drug holiday is not working for you, and what should you do?
Well, depends obviously on your expectations. I think many people make an effort at a drug holiday without adequate information. So they stop the requip and obviously go through anything but a holiday and then abandon it two or three nights. They might last 3 nights, but often it's only 2 nights. That's because they had no idea what the goal was. They had no idea where where this was leading. You know, by night 2 or night 3, you're telling yourself, there's no way I can live like this. No way. Because you don't know that things are going to get better. And therefore, the drug holiday in that situation was ill-conceived and lacked the information to know what was going to happen and where it would lead. And so, as I said, drug holidays are driven by people's expectations because they want to reevaluate or reassess whether they need this or they're having problems, they want to do it. And so you have I guess the question is if you have a problem, you're not sure whether it's related to the drug, you can come off the drug and find that the problem that you had is still there. Therefore, you realize the drug holiday was valuable because you discovered that this problem has nothing to do with the drug, and you could probably just go back on the drug. That'd be one reason to do it. Obviously, you could come off the drug and find that side effect has gone away. You say, well, that's great, and therefore decide to go on to an alternative medication or go back to the drug and maybe get away with lower doses. So the failure is in part what you expect. What are your expectations? How well planned are you? What is your expectations in terms of duration off the drug? All those things. So that's I don't know what else to say beyond that.
So when you have a patient that comes in that's augmenting who wants to do a drug holiday, do you kind of give them a game plan saying you need to plan like a time in your life where you could take off some time from work to do this 10-day holiday? Here's what you need to expect. You kind of need to get your family in tune with this so you have a great support system and, you know, kind of help them line it up, for lack of a better description?
No, I mean, that's exactly. I spent a fair bit of time with my patients that first come to me to go over the whole thing. So I have typewritten description of exactly what happens during that 10-day. I mean, it's verbatim. It is a composite of what my patients have told me. So it reflects as close to the truth that just about 98% of patients will experience during it. It's very, very, very stereotyped, amazingly stereotyped what happens during that 10-day drug-free period. But again, I said, in the end, you need to set aside time for this. You can't. It is not something you do 5 days before you take a holiday. You know, I'm going on a cruise in 5 days. Can I start it now? No, you can't start it now. I mean, let's be practical about this. So yes, I mean, you have you do, and work-wise, I mean, definitely during that 4-day period, that first 4 days of the drug-free period, you are probably not going to drive and be able to work, and then you have to plan that in to your holidays or whatever you need to do about your job. Most people, actually, believe it or not, are able to go back to work on day 5 or day 6, even though they're not getting much sleep. But being active and busy is what they do fine at, and work is a place to be that they can be active and busy. So it's so yes, an enormous amount of plan, layering a plan, decision making, laying out timelines. They should all be done ahead of time. You're going to do this. You don't want to do this without planning and just out spur of the moment. It's not going to work.
That sounds like excellent advice. Well, we're winding down here, but before I let you off the finish the call, we would like to know, are there any new medications on the horizon for RLS treatment? And also, what do you see in the future for RLS research?
I hate to say this, but I do not see any new drugs. The pharmaceutical industry has completely dropped RLS as now, I don't know that we were talking to several companies prior to the recession back in 2007, 2008, but financial things in the drug industry are just as bad. They are concentrating on things like cancer, stroke, multiple sclerosis, heart disease, things like that. Restless legs, I can guarantee you, is really not even on the radar. We've, again, tried to reinstitute some interaction with drug companies. We get some meetings and things like that, but it drops there. So unfortunately, I don't see anything on the horizon. I think the issue of marijuana, with the increasing legalization of it, is opening the opportunity for someone at some point to do at least a reasonable drug trial, at least some evidence of value for this drug. I think once it does become legal within the individual states, I am sure there'll be plenty of RLS patients who will try it, and I have no doubts it'll work for some people. Will it work for everybody? What's the long-term side effects when you have to use it? Those will have to be discovered. In terms of science, I think there's a lot of good science. We have eked along in some meaningful way in the last 4, 5, 6 years with the recession. Again, the NIH is not giving a lot of money, and RLS is not anywhere near the top agenda for NIH support. But there has been some nice work done at different places. I think the issue of the glutamate system, tying it into the dopamine system, some of the newer genetic stuff, I think they will produce some hopefully interesting models that we can go forward to test new drugs, and that's where I'm hopeful that we'll get to some resolution about the more complex biology behind restless legs, both in terms of transmitters and genetics, so we can develop quick systems that have a reasonable representation of the underlying problems in RLS, in which we can then test various chemicals and hopefully come up with new drug treatments.
Dr. Early, thank you so much, and I will make a pitch for the foundation. We are the only organization that supports RLS research, and Dr. Early actually serves on our scientific advisory board and reviews the proposals submitted to the foundation each year for consideration of a grant. So I want you to feel hopeful about it, that we are not dropping the ball at the foundation. But Dr. Early, thank you so much for taking the time to present this very important webinar to the RLS community, and we thank you for your work and your commitment to the cause.
Thank you very much.
All right. Take care. Bye-bye.